All right, let's dive right into this explainer. Today, we're looking at a truly monumental shift in women's health that officially happened in May 2026. For decades, millions of women have been navigating a condition known as polycystic ovary syndrome or PCOS. But that name, it's officially out. The medical community has officially renamed it PMOS, Polyendocrine Metabolic Ovarian Syndrome. And it's so fascinating to unpack this because it isn't just some superficial rebranding. It is a massive leap forward in how we actually understand the complex biology of women's bodies. We've got a lot of ground to cover today. Saying goodbye to the old name, digging into diagnosis, unpacking the 7 root drivers, looking at the clinical edge approach, and finally, protecting your long-term health. Let's get right into it. All right, part 1, goodbye PCOS, hello PMOS. For literally decades, we've been using a name that completely missed the mark. The old acronym PCOS placed way too much emphasis on just the ovaries. It fundamentally missed all the whole body metabolic and hormonal changes that were going on. But PMOS, Polyendocrine Metabolic Ovarian Syndrome, that finally hits the nail on the head. It accurately describes what is actually a complex whole body condition, affecting insulin, reproductive hormones, your weight, skin, hair, and even your long-term cardiovascular health. Imagine hearing for years that your ovaries are covered in abnormal cysts. Well, guess what? That's a total myth. Those things doctors see on an ultrasound, they usually aren't abnormal cysts at all. They're actually just numerous, small, immature ovarian follicles. Basically, eggs that just kind of paused and didn't progress normally through ovulation. Honestly, a woman can even meet the diagnostic criteria for this condition without having those polycystic-looking ovaries at all. Let's actually break this new acronym down because it validates so much of what women have been experiencing. Polyendocrine means we're dealing with multiple hormonal systems, not just one. Metabolic calls out the real heavy hitters like insulin resistance and blood sugar regulation. Ovarian confirms that, ovulation and androgen production are still key pieces of the puzzle. But syndrome, that is the crucial part. It means this looks completely different from person to person. You can have lean women struggling with acne and hair loss, and other women dealing with profound insulin resistance despite having perfect blood glucose. You just can't reduce it to a single symptom. Moving on to part 2, how PMOS is actually diagnosed, because while the name changed, the core criteria did not. So for adults, doctors are generally looking for at least 2 out of 3 specific things. Number 1, irregular or absent ovulation, skipped periods. Number 2, signs of elevated androgen activity, like high testosterone, which might show up as stubborn acne or unwanted facial hair. And number 3, that specific polycystic look on an ultrasound or a high AMH hormone level. But again, if you have those first 2, you don't even necessarily need that ultrasound for diagnosis. But wait, before any doctor stamps PMOS on a medical chart, they absolutely have to play detective. It is so incredibly important to rule out copycat conditions first. Things like thyroid dysfunction, elevated prolactin, or even rare stuff like Cushing's syndrome or an androgen-producing tumor. If a woman is suddenly growing facial hair out of nowhere or her voice is deepening, that needs rapid medical evaluation. You literally cannot just assume it's PMOS. All right, part 3, the 7 root drivers. Let's look at the why. There is this massive interconnected web of physiology at play here. There isn't just one single root cause. It's usually a mashup of a few drivers. Think about it. Insulin signaling and excess androgens totally feed off each other. Throw in some altered brain ovarian signaling, some genetic susceptibility, maybe some poor sleep and chronic stress, and boom, you've got a completely unique metabolic fingerprint for every single woman, which, by the way, is exactly why cookie-cutter treatments just do not work. Let's actually zero in on insulin resistance for a second, because it is a massive player. Here is the mechanism. When your cells stop responding well to insulin, your pancreas basically panics and pumps out even more of it. That excess insulin, it acts like a giant megaphone yelling at your ovaries to make more testosterone. It also tanks a protein called SHBG, which normally keeps testosterone in check, meaning you get way more active testosterone in your bloodstream. And here's the absolute kicker. This happens in women of literally any body size. Your fasting blood sugar could look flawless for years while your insulin is quietly skyrocketing in the background. We have to test for it. We can't just guess based on how someone looks. Which brings us directly to a super important point. Yes, adipose tissue, or visceral fat, is metabolically active and can release inflammatory signals that make symptoms worse. But just telling a woman with PMOS to simply lose weight is medically inaccurate and, quite frankly, incredibly unfair. It completely ignores the brain signaling, the genetics, the underlying hormones, and it just piles unnecessary shame onto a physiological condition she literally did not cause. Which naturally leads us right into part 4, the clinical edge approach to treating the individual. Instead of just handing out a birth control pill to mask a period problem, the Clinical Edge uses a brilliant 6-step cellular medicine methodology. They start by gathering clues, confirming the exact pattern of your history, your sleep, your cycle timing. Then they evaluate your metabolic health and hormone signaling through targeted testing. Only then do they work on restoring metabolic flexibility and pulling in targeted support. It's all about building a highly personalized roadmap, not forcing everyone onto the exact same restrictive diet. Step 4 is actually fascinating. It focuses entirely on restoring metabolic flexibility. Yes, they talk about food, prioritizing whole foods, but it's not some extreme zero-carb nightmare. The carb intake is highly individualized. They also heavily prioritize resistance training, since your skeletal muscle is essentially your body's biggest glucose sponge. But get this, they treat sleep quality, stress regulation, and circadian consistency as non-negotiable medical care. In the context of PMOS, managing your stress and getting solid sleep aren't just nice-to-haves. They are absolute medical requirements for regulating insulin and calming inflammation. Now, when those foundational habits need a boost, we hit step 5, targeted support. And the modern toolkit here is huge. We're talking myo-inositol combinations, fixing basic nutrient gaps like vitamin D and magnesium, or even pulling in medications like metformin or GLP-1s if metabolic disease is present, with very careful screening, of course. Depending on a woman's reproductive goals, it might mean hormonal contraception or cyclic progesterone to protect the uterus, anti-androgens for hair loss, or even fertility medications like letrozole. The whole point is that the support is precisely targeted to her specific biology. And finally, part 5, protecting your long-term health. It's way beyond just the symptoms. Because, let's be real, managing PMOS isn't just about clearing up some acne. It is about playing the long game. Women with this pattern have a statistically higher risk for prediabetes, type 2 diabetes, fatty liver disease, and abnormal cardiovascular profiles. There are also mechanical risks like sleep apnea. And from a gynecological standpoint, if you aren't shutting that uterine lining regularly, it's exposed to way too much estrogen without enough progesterone, which requires medical management to protect it. Oh, and we absolutely have to screen for anxiety, depression, and body image distress. The mental health toll of navigating this endocrine condition is incredibly real and needs just as much attention. Honestly, if you only remember one single thing from this entire explainer today, please let it be this exact quote. PCOS is not a personal failure, and it is not simply a disease of ovarian cysts. It is a complex, whole-body metabolic and endocrine condition. Shifting the focus completely away from personal blame and away from this hyper-focus on just the ovaries is hands down the greatest gift this name change brings. Now, logistically speaking, you're probably still going to see PCOS floating around on insurance forms and medical pamphlets for a while. Massive bureaucratic systems take forever to update their paperwork. But rest assured, your core diagnosis hasn't vanished. The medical establishment is just finally catching up to the reality that you and millions of other women have literally felt in your bodies for years. So, I want to wrap up and leave you with this final thought. Now that the medical community has finally updated the name to reflect your whole body system, how is this new understanding going to empower you? Will it change the way you advocate for the personalized care you actually need in the doctor's office? Because armed with the knowledge of PMOS and its actual root drivers, you aren't just masking a symptom anymore. You finally have the blueprint to understand your entire system. Thanks so much for tuning into this explainer and keep asking the right questions.